Welcome to today's lecture on substance use disorder. Today's lecture will cover more looking at alcohol and drug use, and that can include prescription drugs, non-prescription drugs, and street medications as well. It is important to understand that the biggest thing that we're looking at when it comes to substance abuse is that individuals withdraw and the critical care that's going to be required. So please make sure you review this portion of your withdrawal sheet within your textbook. Objectives and outcomes include describing the continuum of substance use disorder, the behaviors, analyzing predisposing factors, looking at coping mechanisms related to substance use disorder, identifying outcomes, and developing a nursing care plan for individuals with substance use disorder. When it comes to continuum of chemically mediated responses, we're looking at it being adaptive or that natural high that may be related to more so what we see like physical activity and meditation. So that's good high. But when it's maladaptive, that's when an individual is dependent upon a substance like tobacco or alcohol, and they begin to abuse it to the point of being dependent upon it. With substance use disorder, it's a maladaptive response that affects people's relationships throughout any age. It affects their ability to, when it comes to work, home, school, having relationship with friends, and it creates hazardous situations and including legal problems. Substance use disorder is a result of excessive use, and it causes, again, personal but also social problems. Any drug that produces a pleasurable brain change can be abused. So alcohol, prescription drugs, heroin, cocaine, marijuana, and inhalants, and please understand the difference between the two and the different kinds. When we're looking at diagnostic criteria, we're still continuing to see the use of the DSM-5 that lists all those substance use disorders. But there's also impaired control over substance use, a social impairment, risky use of substance and failure to abstain, pharmacological effects, and then the gambling at that portion that activates that brain reward system. So just kind of look at those little things. Think about not only the diagnostic criteria within the DSM-5, but also looking at your nursing diagnosis, that impaired control over substance use, that social impairment, and the risky use of substance and failure to abstain despite difficulty. Other categories of substances include alcohol, caffeine, cannabis, hallucinations, inhalants, opioids, sedative hypnotics, stimulants, tobacco, and there can be others that continue to grow in this market, especially things that are coming up recently. I heard of Skittles. So more and more things are coming up. And it's our job to be aware of what those things are and then try to put them within a category as you see here listed. Impaired control is that inability of an individual to avoid or control their need or use of it. So they begin to take these substances in larger amounts over a longer period of time. They have this persistent desire, and they're not able to regulate that desire. They actually lose the ability to regulate that. So they spend a lot more time trying to obtain the legal or illegal substance in order to recover from the effects of that withdrawal. And so they continue to have these cravings. With social impairment, individuals, because of their recurrent use of substances that impair their ability to have control, have failure when it comes to work, school, or home and obligations, and it may not start off that way initially, but eventually they find it more and more difficult to be able to sustain that. They will have social and interpersonal problems. Occupational and recreational activities will reduce. The substance use will increase, and they may withdraw from family interactions. One of the biggest risks that comes with substance use and failure to abstain is the hazardous situations and conditions that it can create. And despite an individual's knowledge of how it affects them physically or psychologically, they still continue to use these substances. Over time, tolerance begins to develop. Withdrawal symptoms will occur as a result of not having it, or as their blood and tissues realize that there's a lower concentration of the substance, their body will begin to show signs and symptoms of withdrawal. Substance-induced disorders are when medication are used for health problems or mental treatment causes intoxication, withdrawal, or other health-related problems. But with substance use disorder, this individual continues using despite knowledge of the cognitive, behavioral, and physiological symptoms that may develop. With substance dependence, it's a severe condition or disease in which the physical problems and that lead to a disruption in their work, their family, and their social life. With addiction, this is a psychosocial behavior related to substance dependence, and it's a condition that results due to continued use of a substance or the need to have this reward seeking despite the consequences. With withdrawal symptoms, these effects result from a biological need when the body begins to adapt to that drug, and now it needs it, and if it doesn't have it, it begins to show signs and symptoms. And with tolerance due to a continued use or abuse, the substance no longer has its the effect that it would normally have at the amount it is. With alcohol tolerance, that's the ability to be able to ingest an increasing amount of alcohol before actually experiencing a buzz. So when we think about tolerance and we're thinking about drug and alcohol, we're saying initially a person could have a beer or have a couple of shots and before they can have a buzz. But prolong a couple of shots every day, eventually they need more. And so now a couple of shots won't do anything for them. They need to have 3 or 4 in order to receive that. And so that's the complication that comes along with tolerance and also leads to abuse. The prevalence of substance abuse is so high, especially in our state. It's the highest level probably in the whole world. People see it in every care setting. It touches every socioeconomic group. It results in motor vehicle accidents, suicide, sexual assault, high-risk sexual behavior, and even teenagers have moved from nicotine to alcohol to marijuana to even more increasingly dangerous drugs. 50% of adults are arrested due to drug use and test positive. Alcohol plays a strong role in domestic violence. And when you have alcohol and depression as a higher prevalent, drug abuse comes right up in there, third most common as far as diagnosis for men. 45% of med-surg patients and 20% of outpatients have substance abuse as a primary problem. So, and I'm quite sure these numbers have grown increasingly higher since being posted in this PowerPoint. Alcoholism is the most abused substance next to marijuana. It is the result of 50% of auto accidents, 68% of drownings, 54% of fires, and 48% of serious falls. The comorbidity when it comes to substance abuse includes mental disorders, whether it be psychosis, anxiety, mood disorder, personality disorder, and more than 67,000 Americans died from drug-involved overdoses in 2019, including illicit drugs and prescription opioids. So it's really important as nurses that we be aware of our patients and asking those questions about their medications and being straightforward and asking them whether or not, asking questions to determine whether or not abuse of substances might be a problem that exists with them. When we come to etiology, we're looking at different types of internal and external or intrinsic and extrinsic factors. So there's a biological component that says there's a genetic predisposition. However, there's no genetic markers really found. The psychosocial component says that a person's temperament, their feelings about themselves, the motivation they need to change, the social consequences, their relationship with their family, and peer pressure play a role in an individual either succumbing to or avoiding substances. Attitude can also play a factor, especially when it comes to social and cultural norms. The law may be tougher for DUIs. And I think that's what's really happening. Most people don't even seek treatment just because of how they view their alcohol use. And a lot of times that can be also associated with the fact that they're in denial. They'll go to the point of even hiding their substance abuse history. And as a result, it puts them at risk for drug interactions or misdiagnosis, which is still back to the point of your role as a nurse and making sure that you reach out and you're asking those assessment questions to determine the risk for your patient. When it comes to dual diagnosis, and any of you who are working on our dual diagnosis units, these individuals have substance use abuse and alcohol abuse that coincide with other psychiatric disorders. And as a result, they, instead of seeking help or following through with medication treatment, these individuals end up self-medicating in order to deal with their depression and anxiety, or to help it counteract any side effects from the medications that they're using. It could be, again, back to genetics as an issue for individuals, but there's not really a relationship. But I will say this, I think that it still lends to the fact that most individuals with substance use and alcohol abuse will say that they use alcohol to treat a mental issue that they're dealing with. Implications related to substance abuse. It goes frequently undetected and is underdiagnosed in acute settings. So we need to be paying attention. Because of the negative attitudes towards substance abusers in healthcare settings, we need to advocate for them so that they can get help. Sometimes that's the reason why they don't want to get help, because caregivers aren't able to prevent patients from seeing how they feel, especially if a healthcare provider has a family member that they're dealing with it. Then they can't help but do counter-transference and put that information, put them feelings that they're having onto the patient. And so patients, they realize this, and they don't want to receive care and be judged at the same time. But it's really important that as nurses, we advocate for our patients. We encourage them to attend meetings with self-help groups, use self-help groups in order to recover from alcohol and substance use. Common behaviors are listed here. Please read over these, um, looking at different characteristics, behaviors that you might see with someone who uses substance, use prescription medications, abuse it, or have a substance addiction. So just read over that information. And even on that next slide, when it comes to assessment, I think this will help you out definitely. And again, assessing, looking at their history, what type of medications are they on, making sure that they're not doctor shopping, what over-the-counter drugs are they using, how much caffeine and nicotine are they taking, and do they use alcohol every day? A type of assessment that we can use for alcohol is your CAGE questionnaire. This is a frequently used tool. Sometimes individuals feel like when you're asking these questions that that you might be criticizing them, so they might not be as accurate or a little bit annoyed with you to be asking, but it's important that you do it. And sometimes when you can do this, it's an eye opener for that individual. It is a patient can be able to identify whether or not they are individuals who engage in eye opening, and that's that early morning drinking. But I also say with this that if you really have somebody who's in for rehab and interested in cutting back, when you use this CAGE questionnaire, it's really eye-opening for them as well, because they begin to equate or have to put down on paper or recognize how much they actually drink compared to what they think they drink. With drinking history and assessments, we should be able to ask them questions like, what do you drink? How much do you drink? When do you start? When did this drinking start? When did you have your last drink? How often a day? What problems has alcohol caused for you? And the more information you ask, then the more information you'll be able to obtain from your patient. There are other screening tools that I've listed on here because I know that they're going to show up on your HACCP and also on your NCLEX. So you need to know that AUDIT is your alcohol use disorder identification test, and that BDAS is your brief drug abuse screening test. Other ways that they can test is using breathalyzers or assessing for signs and symptoms. Blood alcohol levels can also be done. Please see the table in your book as well. Other abused substances that we're looking at, and we talked about these before, and I have these on the slide, but I give some examples of your CNS depressants that include alcohol, inhalants that are glue and lighter fluid. You have your stimulants, most of the time, most common in this area is amphetamines. Cannabis, most common is marijuana. Hallucinogens, you still see MDMA and LSD. Nicotine is on its high. Phencyclidine, phencyclidine, however you want to pronounce it, PCP, that medication, I still see opioids, heroin, codeine, caffeine, sedatives, hypnotics, and anxiolytics are on that list. We talked a little bit about this, and just to reiterate, the consequences of individuals who engage in substance abuse is high, and that's what that prevalence is, because there's accidents, violence, self-negligence, injury to fetus or infants, infections, including hepatitis and AIDS. The cause of addiction can have a psychodynamic effect. Not so much that it's about a personality or addictive personality type, or again, we go back to Freud, in which some of you don't want to hear me talk about it. The idea that maybe there's a fixation at an oral stage that makes a person dependent. when you look at your disease model, more what you see from a medical standpoint is that when it comes to addiction, it's chronic, it's progressive, it can be relapsing, incurable, and potentially fatal. That there is some predisposition through inheritance, and that has been identified. And when it comes to this disease model, many medical professionals, I think, accept this model more for using to help treat individuals and to help them recover. Is it behavioral, overlearned, maladaptive habits? I do believe that there is a behavioral aspect to addiction. With biological, persons can be born with inherited sensitivities to certain substances, and then there are some cultural beliefs that alter what a person thinks about alcohol or how alcohol is used that can lead to an addiction, or even other substances. So how does a person cope? You have to ask them the questions. You need to ask questions to determine what those coping mechanisms are. What is the person's motivation to change? Do they have social support? What's their health status? What are their social skills? And looking at personality traits to help them look at positive ways to reinforce change. Other coping mechanisms can be positive problem focusing, helping them learn how to do that. And then to avoid ego defense mechanisms that include denial, rationalization, and projection. And you will need to know the definitions of these. Primary nursing diagnoses include disturbed sensory perceptions, acute confusion, ineffective coping, and dysfunctional family processes, and then alcoholism that goes with that. Expected outcome. When an individual is going through withdrawal, we want to keep them safe and then minimize any discomfort. We want to make sure that they can be alert and oriented. Have them be able to report any symptoms that include symptoms related to withdrawal, including hallucinations and delusions, and that they can interpret correctly any environmental stimuli. Short-term goals, which is going to be really important for you guys to remember, is that the patient will agree to remain drug and alcohol free for a certain period of time, and it's usually a week. And that they'll make a daily commitment to abstain. Remember, daily. They have to take one day at a time. And then at least attend 2 support groups weekly. And then they'll contact a support person if they're experiencing the urge to use or drink. Long-term goals is abstinence. Just remember these 2 slides. Short-term and long-term goals. Abstinence will reduce substance use, reduce frequency and severity of relapse, and improve their psychological and social functioning. When it comes to withdrawal, the biggest priority we have right there is safety. We want to stabilize physiological status, and then go into the mental, and then address any abstinence and support system issues. With treatment planning, we're thinking about getting that patient to motivate change using therapeutic relationship and creating that alliance with them. We want to assess the environment and the patient for their safety, manage their intoxication and withdrawal syndromes, reduce any damage that was caused by the substance use, create a treatment plan, help them to develop abstinence to prevent relapse, and then giving them education on substance use disorders. I have posted that again, withdrawal, just making sure that you guys look over this one. Remember that withdrawal can happen, an individual can show early signs within 6 to 10 hours after their last drink. So you're going to be asking them questions like, when was your last drink? They can have signs and symptoms of anxiety, anorexia, insomnia, and tremors, other jerky hand movements, hallucinations, nightmares, nausea, and vomiting. When you're doing their vital signs, you're going to see that their pulse and blood pressures are going to be elevated, and they may even have grand mal seizures within 7 to 48 hours after their last drink. When they get to the point of delirium, that can happen 48 to 72 hours after their last drink. This becomes a medical emergency because it leads to 20% mortality rate amongst individuals who are at this state. These individuals will have tachycardia, increased blood pressure, diaphoresis, and their blood pressure is going to be extremely high. They're going to be disoriented. They're going to have visual and tactile hallucinations. Their level of consciousness is just going to be fluctuating. They're going to be agitated. They're going to have a fever. They're going to be terrified, confused, and anxious. And so you're doing a lot of multitasking. But at this point, physiological needs come before the mental needs. With alcohol withdrawal delirium, we want to make sure that the environment is therapeutic, keeping it calm and quiet to reduce excitability to the central nervous system. So we're going to promote relaxation, again, calm, quiet voice, place clock in sight so they can keep in check with reality, not to leave them alone because it's almost just as bad as leaving a severe panic patient who has anxiety alone, and then treat the patient with dignity and respect. When you're treating the symptoms of detoxification, you want to make sure that you're giving them fluids to reverse the effects of dehydration and encouraging them to eat. You want them to have frequent sips of milk. We're going to give them something, an antidiarrheal agent, because that's one of the side effects withdrawal. Put them on seizure precautions, and especially based on your facility's instructions. Give them a cool cloth for their forehead to help with the nausea. Help them with position change, not to move so fast so that they don't go into vomiting. And then give them medications and vitamins based on the prescribed order of the physician. Medications that you're commonly going to be seeing used are long-acting benzodiazepines like Librium, Valium, Ativan. Monitor for toxicity of benzodiazepines, and that's kind of the biggest, hardest problem because the same medication used to withdraw an individual has its own addictive properties. So you want to be watching them and making sure that they don't have ataxia, which is difficulty walking, or nystagmus, which is involuntary eyeball movement. Thiamine and vitamin B12, we usually give them to prevent Wernicke's encephalopathy and Korsakoff psychosis. So, and that's usually what you'll see is that banana bag that they're given that has that replenishment of those electrolytes. For psychosocial interventions, identify what their triggers are. What happened just before they decided that they needed to engage in substance use abuse? Promote family counseling and group therapy because they're going to need help on both sides. And then using self-help groups. And remember, self-help groups are groups that are managed by someone who deals with the same problems that they have. And different types include Alcohol Anonymous, Women's for Sobriety, Rational Recovery, and Narcotics Anonymous. So the ones I see more so are AA and NA. Al-Anon helps the family members of alcoholics cope with living with an individual who is an alcoholic. And then you have ACOA, which is your adult children of alcoholics. And this group is to help children who have had to live with the effects of having an alcoholic in a home. and it helps prevent them from having low self-esteem. It just kind of tries to break the cycle of it repeating. With treatment for your dual diagnosis patient, you're going to treat the symptoms in the sequence in which they come by using pharmacological medications, psychosocial treatment, and other supportive services. With opioids that include morphine and heroin, withdrawal signs include runny nose, tachycardia. They can have fever, insomnia. We're going to just be monitoring their vital signs, remaining with them, giving them foods and fluids, and then we're going to be giving them medications. Commonly today, the one being used and has such conversations about is Subutex. With amphetamines, your withdrawal includes depression, fatigue, they're feeling down, they're going to have suicidal thoughts, maybe paranoia. Again, monitoring their vital signs, looking to see if they're harming themselves or others, promoting sleep and rest and eating. Remain with the client though sometimes because their vital sign changes, or frequently checking on them because of the effects of the withdrawal from this medication. And then we may also use antidepressants. With cocaine, depression is there, fatigue, suicidal thoughts, paranoia. We're monitoring their vital signs, looking for suicidal ideations, promoting sleep and health, making sure they're eating and drinking, and remaining with them, making sure that they're oriented and giving them medications. Withdrawal from LSD or other hallucinogens, they may have flashbacks of a later time. We're going to administer diazepam, especially if they have severe anxiety when they're having these flashbacks. With PCP, withdrawal signs can be depression, lethargy, and craving, and a lot of just similar nursing care is present. So you're kind of doing the same thing. When you're looking to determine whether or not an individual has signs of chemical dependency, especially in nurses, we're looking for mood swings, non-compliance with policies and procedures, poor appearance, poor job performance, charting errors, alcohol and breath, forgetfulness, lying, high achievement, volunteering for overtime, onset after surgery, family history. Maybe they're volunteering too much to help pass meds. These are things you're going to be looking for. 6 to 8% of professional individuals are impaired by alcohol or some type of drug, and they're reluctant to seek help because they're afraid that they're going to lose their license. However, we need to intervene when we know that we're working with a colleague that's impaired. So once we identify an individual, then safety is of highest concern. Safety for the patient and then safety for the nurse. Mandatory reporting, so it's not an option. And then making sure that this is reported to the supervisors, and then sometimes making sure it's properly documented. There, within each organization is some type of employee assistance program that promotes early intervention to reduce hazard to patients and therefore increasing the prospect of the nurse's recovery. When treating a person who is impaired, the supervisor maintains contact with the treatment program to see how that individual is performing, and then they're allowed to return to work with clearly defined responsibilities, and the EAP monitors their progress, and in order again to remain employed, this process has to be gone through.